Hi, this is Dr. Nick with the ECG Academy, and this chapter is about a certain kind of atrial tachyarrhythmia that we affectionately refer to as SVT, or supraventricular tachycardia. Now, you might say, well, what's the difference between atrial tachycardia and SVT? Well, to tell you the truth, it's a little bit of semantics, but what I like to say is that if you can see discrete P waves in front of each QRS complex, then we like to call it atrial tachycardia because we know it's coming from the atrium. But sometimes rapid heartbeats from the top chamber actually originate within short circuits involving the conduction system. And often it's better to call them supraventricular tachycardia to basically distinguish them as being from tissues above the ventricle, but not necessarily directly from the atrium itself. Now, in the last video, I talked about paroxysmal supraventricular tachycardia, or PSVT, and that's more of a clinical diagnosis, meaning the patients will feel a rapid heartbeat that starts and stops fairly suddenly, and it can go on for minutes or hours or even days. Now, the kind of mechanisms that cause atrial tachycardia we'll discuss in the intermediate section when we deal with mechanisms of arrhythmias. But suffice it to say that sometimes atrial tachycardia can occur because the electrical signal is traveling round and round in a circle. We call that re-entry. And sometimes atrial tachycardias can arise from one little spot in the atrium that starts to fire rapidly, and the signal sort of spreads outwards. And we call that more of an ectopic focus or ectopic atrial tachycardia. But that's diagnosis that is sometimes difficult to make just from the ECG. And if you just call it atrial tachycardia, that's generally enough. Of course, we'll deal more with this in the advanced course. But we'll talk about PSVT because PSVT is a very common problem. We see it in the emergency rooms, and we can see it on Holter monitors and whatnot. Now, with PSVT, basically the problem is coming from above the ventricles somewhere. One of the more common arrhythmias that we'll see originates from the AV node itself. And you see these transitional fibers. They are the anterior fibers here and the posterior fibers here. Well, sometimes you can get the signal getting stuck, going down one pathway and back up the other. And you have this signal that basically chases itself round and round in a circle this way. And that's probably the most common cause of PSVT. That's actually known as AV nodal reentry tachycardia, or AVNRT. As I said, we'll go over this in great detail in the advanced course. The other mechanism that we'll sometimes see, we touched on briefly in the section on interventricular conduction disturbances, or IVCDs, because people can sometimes have an accessory AV pathway, like a WPW kind of syndrome. And there, the electrical signal can actually get stuck going down the AV node to the ventricles and then back up this accessory pathway to the atrium, giving rise to a very large reentry circuit, sometimes known as macro reentry. Now, this is getting into some advanced stuff, but basically it causes a rapid heartbeat that starts suddenly, arises from above the ventricles, and gives rise to a narrow QRS complex, rapid regular arrhythmias. Now, on occasion, you'll see what looks like PSVT, but it's actually arising from the atrium itself. Sometimes you'll actually have atrial tachycardia where the signal is either going round in a circle or whatnot. Sometimes you can have ectopic atrial tachycardias as well, but they'll be hard to distinguish from the other kinds of arrhythmias that I mentioned. But at least you can kind of lump them together as supraventricular tachycardia, and that would be the correct diagnosis. Well, let me show you the first example of a sustained tachycardia where it's unclear what the exact mechanism is, but you can at least diagnose it as supraventricular tachycardia. Now, here's one example of supraventricular tachycardia, and this would be a patient who maybe walked into the emergency room with palpitations or lightheadedness. And this is a 12 lead, and when you scan across, you can see that the QRS complexes appear to be quite regular. And if you look for a QRS that lands on a solid line, you can count off 300, 150. It's about maybe 120 something. But remember the trick, look for two QRS complexes and count off that. So here's one and here's another. And those are exactly, let's see, 300, 150, 100, 75, 60. So if you count 60 beats per minute for 2 beats, then 1 beat has to be 120 beats per minute. What you should recognize immediately when you look at the P waves in front of each QRS complex is that they're inverted. They're upside down, they're inverted in the inferior leads. And that tells you basically that the P wave vector is headed towards the head. That means they have to be originating somewhere down in the low part of the atrium and then traveling upwards. And it couldn't possibly be sinus tachycardia. It has to be some kind of ectopic focus. So we can call this ectopic atrial tachycardia, which gives us a little bit of a sense of what the mechanism is. But some people would just simply refer to this as supraventricular tachycardia. And it is sustained. You can see it just goes on and on and on, and this patient was in it for hours. So the mechanisms that cause tachycardias like this are variable. Sometimes it may be due to a focus that's firing rapidly, but in this case it turned out to be a short circuit involving the AV node. I want you to be able to recognize this kind of supraventricular tachycardia as being regular, narrow QRS complex with a P wave that's generally 1-to-1 association between the P and the QRS with a fixed PR interval, and you'll sometimes have to actually give the patient medications to get it to break. Now, this kind of sudden onset, rapid regular rhythm is often referred to as paroxysmal supraventricular tachycardia, or PSVT. And PSVT is generally considered to be due to short circuits, often involving the AV node. Just be able to recognize this as an abnormal rhythm because you see these inverted P waves, and so you're safe to call it an atrial tachycardia. You know that these P waves are inverted, and so the arrhythmia came from somewhere outside of the sinus node, so ectopic atrial tachycardia would be a little bit more specific. And if you want to suggest that this is a mechanism perhaps involving the AV node, then PSVT would be an appropriate diagnosis. But this has a lot to do with how the tachycardia behaves. The behavior of the tachycardia is how it starts, how it stops, what kinds of symptoms it causes, and how it responds to medications. And PSVT is more of an electrophysiologic diagnosis, whereas if you just take the cardiogram at face value, it's reasonable to just call it an atrial tachycardia. Finally, I'm going to show you this electrocardiogram, which most cardiologists would simply label this as SVT, supraventricular tachycardia. The mechanism is a little bit difficult to determine, but if you look at the forest, you see it's a very regular tachycardia. It's quite fast here. If you take 2 QRS complexes and measure the rate, it's 300, 150, 100. So we're talking 200 beats per minute. So at 200 beats per minute, it's regular. It's narrow, complex. Are there P waves that you can identify? Not easily. In the advanced course, I'll show you how to look for evidence of P waves in this kind of a tracing, but it's safe to say that the P waves in this tracing are not really visible. They're almost certainly buried within the QRS complex. And in fact, you see a little tiny negative deflection at the tail end of the QRS that's likely the P wave peeking out from behind the QRS. So you would call this supraventricular tachycardia if the patient described that it started suddenly and he came to the emergency room and got an injection of something like adenosine or diltiazem and it breaks suddenly, then you would call this paroxysmal supraventricular tachycardia. But again, that's a diagnosis that's kind of based on the behavior of the arrhythmia. It's more of a clinical diagnosis. The electrocardiographic name for this would be SVT. You don't see those discrete P waves in front of each QRS complex, so atrial tachycardia would be less appropriate under these circumstances. It's getting a little complicated, but watch these videos over and over again and listen to the rest of the videos in this section, and it'll make sense to you. And you'll get lots of practice reading these things on the Chalk Talks if you subscribe to those weekly discussions on unknown ECGs. That's where you'll really get used to reading these more difficult tracings. So, for the ECG Academy, this is Dr. Nick. Thanks for watching.